In this presentation, we will cover the diagnosis, assessment, and treatment for a patient who comes into the ER presenting with signs and symptoms of Ludwig's angina. An adult male arrives to the ER in the late afternoon. There is significant swelling of the tongue and the submandibular space. His tongue is protruding from his mouth, and he's drooling. He's diaphoretic, and he appears panicked. He's stating that it's getting much harder to breathe, and he's clearly tachypnic. He's assigned an open bed in the ER stat. Upon being admitted to the room, the patient was able to give a brief history. His name is Jonathan Doe. He's 56 years old. He's a full code, and he has no known allergies. He has a past medical history of type 2 diabetes and hypertension. He has no past surgical history, and he worked as an accountant, leading a sedentary lifestyle, but lost his job 1 year ago. He's currently homeless. He reports drinking on average 2 drinks per day and denies smoking or any illicit drug use. He was on metformin and lisinopril, but stopped taking those about 6 months ago. Upon further interview, JD states that he's been experiencing worsening tooth pain and swelling over the last 24 hours. The initial pain was noticed yesterday morning, and the pain is constant, but it worsens anytime he opens his mouth, anytime he speaks, and whenever he eats or drinks. He reports it as a sharp pain in his right lower molar, and there's a throbbing pain in his sublingual area. The pain's been radiating from his tooth throughout his submandibular space and anterior throat. He rates it as an 8 out of 10. JD also states that he noticed some red patches extending from his throat down his chest. JD also states that he cannot remember the last time that he visited the dentist. He states that his hygiene is far from ideal, especially his dental hygiene, given his current living situation and his poor access to resources. Upon the nurse's focused assessment, it is found that JD is in respiratory distress and he's diaphoretic. There's diffuse swelling of the tongue, sublingual, and submandibular spaces. His lymph nodes are non-palpable due to the severity of the swelling. His interincisal distance is limited to 1.5 centimeters. There's a grossly decayed right second molar tooth with visible pus drainage. He's 6'1" and he weighs 81.6 kilos. He's currently 101.8 degrees Fahrenheit. His blood pressure is 160/90, heart rate of 115 beats per minute, respiratory rate of 28, and his SpO2 is currently at 91%. Ludwig's angina is a progressive gangrenous cellulitis and edema of the soft tissues of the neck and the floor of the mouth. A cellulitis is a bacterial infection localized to the subcutaneous tissue kept within the fascial plane. The initial infection is almost always due to poor dentition of the second or third lower molars. It then spreads via the molar roots into the mylohyoid ridge, where it then progresses to the sublingual space. The location of the infection puts the patient at a high risk for complications. It's fatal if it's left untreated, with a mortality rate of 50%. Edema of the tongue and the neck are able to obstruct the airway, and the highly vascularized area of the submandibular space increases the risk of sepsis. When a patient presents with severe Ludwig's angina, airway access is key. You want to ensure airway patency, as the inflammation in the throat is able to occlude and obstruct the airway. Intubation is the typical route, followed by surgical drainage of the edema. A stat surgery is typically scheduled to create submandibular stab incisions for emergent drainage. Then, Penrose drains are placed in those incisions for passive drainage while the patient is treated with medication post-op. The 2 most important medications given to patients with Ludwig's angina include antibiotics such as Zosyn to fight the infection head-on and steroids such as dexamethasone to help reduce the inflammation. Now going back to our patient JD, based on the exam findings from both the nurse and the physician, Ludwig's angina was suspected. An ET tube was placed to preserve his airway, and he was started on Zosyn to fight the infection, dexamethasone to minimize and reduce inflammation, and morphine for pain. A CBC was performed, and his white blood cell count was found to be elevated. A CT with contrast was also done to examine the submandibular, submental, and lateral pharyngeal spaces. This confirmed the diagnosis with an examination of abscess locations, as shown on the right. Emergency surgery for drainage and Penrose drain placement was also scheduled. Following his surgery and his Penrose drain placement, JD was admitted to the medical ICU for continuous monitoring and treatment while he was intubated. He was given IV antibiotics and steroids to keep fighting the infection and minimize the swelling. He was also on a Precedex strip to maintain comfort while he was intubated. The drains were gradually pulled out by the team, coinciding with the reduction in swelling. His vitals had also improved, with a blood pressure of 131/84, temp of 99.2, heart rate of 74, respiratory rate of 20 on pressure support on the ventilator, and an SpO2 of 99%.
So next I'm going to discuss nursing interventions. So one of the main things is to manage this patient's airway. You want to look at their oxygen saturation, perform inline suctioning as needed, put them at least at a 45-degree angle just to ensure adequate ventilation and that you're not obstructing their airway more. You should also do oral care every 4 hours and as needed. This patient is on a ventilator, so all those settings will be set by respiratory therapy, but you should be aware of what the patient is currently at. You should also monitor for signs of worsening infections. You should look at the site and see if there's any increased inflammation, any redness, any odor, anything changing that could indicate that they're worsening. These patients also are at risk for sepsis, as anyone is with an infection, so you should monitor all their vitals, their temp, their heart rate, blood pressure, just to ensure they're not worsening, the infection's not spreading. Wound care, you have to do, because they have gotten the surgical drainage, you should do the dressing change twice a day for those Penrose drains, and you should monitor the drainage, how much, the color, the odor, or just to see if how their infection is progressing. And then finally, because this patient is homeless, they'll need a social care consult. They want to determine where they're going to go after and how they're going to receive care in the future, and especially how they're going to get proper dental care in the future, because that was a big part of the cause of this. Next, I'm going to talk about patient teaching. So you should teach these patients about their medication regimen. They will be on steroids and antibiotics, and they should know why they're taking these and what the possible side effects are. For the steroids, that is to decrease the inflammation, and for the antibiotics, that's just to eliminate the infection that they have. You should also teach them of signs of future infection. This infection might reoccur if they don't get the proper dental treatments, and so they should know the signs when they should call the hospital. And that would include having a fever, having mouth opening restrictions, if they feel a firm or swollen floor of their mouth, or if they have any difficulty swallowing. Those should all be reported, and to ensure they get proper and quick treatment. And then finally, you should teach them about the importance of dental treatment. Hopefully the social worker can refer them to an affordable clinic and program to get the proper dental treatment they need so that this does not reoccur. Okay, finally I'll talk about the evaluation of this patient. This whole page is 3 days after they presented in the emergency department. So the Penrose drains were able to be removed. They had decreased drainage from the site and decreased swelling and inflammation of the site, so they decided to remove them. The signs of infection were also seen to be decreasing. The patient was afebrile, white blood cells were downtrending, and they had decreased reports of pain. The patient was also able to be weaned from the ventilator, and the artificial airway was removed, and the signs of airway obstruction was absent after they were breathing independently. So they didn't have any trouble swallowing, they didn't have any trouble breathing. And so these are all good signs. They were also able to schedule a follow-up consult with an orthodontist to get the dental treatment they needed, and they were able to find a family member that was able to take them in for the time being. So overall, this patient had a good outcome, and everything is looking good for them at this point in time.